color. Respiratory rate is increased because they're always can't catch their breath. Because remember, the fluid backload is coming on in the heart itself, backs up into the lungs, because that's the issue that you're talking about with left-sided failure. So this person tends to be that person that's a pink puffer. So they sit upright, or they're doing the tripod position, all those types of things. They're pink in color. Respiratory rate is increased. They tend to have their edema in their feet. So it starts at feet and goes up. So when you're looking at them, they have ankles and feet are going to be puffy. Then it can go up. You know, as the edema increases, you can get it all the way up to the knees. Pretibial, when they're talking about right below the knee, sometimes you'll see that. But they still have oxygenated blood. That's why we call it. That's why they're pink. But they're still working to breathe. Crackles in the lungs. But this person tends to have more respiratory complaints. Left-sided heart failure is most common. Can happen from poorly controlled hypertension, because the left ventricle is the ventricle that's mostly affected by heart attacks. Guess what? Left-sided heart failure is what you see in patients. It's because it's the most common type you're going to see. The right-sided patient is the blue bloater. Where's the blood coming from? That's venous return. Deoxygenated blood. That's why they're blue. Because all you got to do is think about A&P in the heart. That's what helps you figure out what's happening with the patient. Now remember, this side, the right side of the heart, backs up into the portal system, which is the liver, spleen. Okay, so that's where the bloating comes from. Is if you back up blood into an organ, it's going to get larger. It's congested. So that's why we talk about the blue bloater. So they have hepatomegaly, splenomegaly. Spleen is enlarged, liver is enlarged, because that portal system is backed up into you. Venous blood is there, so that's the blue part. They're bloated around the middle because these organs are engorged. So they tend to have edema, but theirs tends to be around the middle, because they can have ascites. These are the people when you turn them over. You know how when you go to turn a patient over and you're holding them on the side and somebody put the pillow, and you take your hand away and your handprint is still there, and you go back 30 minutes and your fingerprints are still there, that's the blue bloater patient. Okay? Because the liver damage, ascites, that kind of stuff causes that great edema that you see. Yeah, Karen?
When you gave this lecture before, I wrote down ascending dependent.
Yeah. So this person tends to have stuff all around, you know, when you see them. Now they may have some peripheral stuff too, but they tend to have more stuff here. Okay. Now the thing about it is, they have, usually because they have a history of respiratory problems, the poorly controlled asthma, COPD kind of thing. They don't get really, even if you put them on O2, doesn't get as great as you would see on the pink side. When you're talking about that patient who has left-sided failure. Far less common to have it by itself. All right. Most patients, especially if you have them for a long time, and in the hospital 5 and 6 times, have symptoms on both sides. So they have what we call biventricular failure. Both chambers of the heart have failed over time. But by far, you can have a person that has left, and that's all they have. If you ever have a person that has right-sided heart failure, it will eventually fail the left side. Always. Left does not always go right, but right will always go left. Okay, when you're thinking about patients who have disease. Okay. Now I'm thinking about what's happening. That means the heart is not pumping efficiently, right? So that means that I have backup of blood that's going into places it shouldn't be. So how do I get rid of that fluid? Diuretics. So you're thinking about what you do for this patient. Because that's going to be part of the mainstay of treatment for whatever side, because the thing about it is I have fluid overload that's happening with this patient. The heart doesn't pump as well as it should, so I need to give the patient medications that make it pump better. So those are the positive inotropes. These are things that are going to increase the force of contraction of the heart. The old standby, the medication that you take the apopropos for, DIG, is one of the things that you see given to the patients for that. So DISH may be a medicine. Now, is it used for everybody? No, it's not, but it's used for a lot of them. Coreg is what you see a lot nowadays, because Coreg has beta and alpha properties. It is a beta blocker. Carvedilol is its generic name that you see given to patients. It increases the force of contraction. Okay. We may also see a patient actually get oxygen, right, because that's part of treatment, but it's also something that helps with contractility of the heart. So increasing their SaO2, their PaO2s is going to help with that as well. So I'm going to give that to the patient. Now, if I want to help to move that fluid along pretty well, I may also give some nitrates. It causes vasodilatation, but helps to get rid of some of the fluid as well. Morphine also does that. Especially when you have a person that tells you, oh my God, I can't breathe, I can't breathe, I can't breathe. They're so full of fluid, they may be on the point of pulmonary edema. So morphine is going to help calm the patient, slow the respiratory rate, but morphine also vasodilates. So it'll help if you give them Lasix, it's going to help the Lasix work even better. All things that you end up doing for your patient. Now, even if their blood pressure is low, I may not give it right away, but ACEs or ARVs are going to be drugs I give to the patient. Because those are the things that decrease ventricular remodeling. So sometimes, depending on what's going on during the acute phase, I may not add them just that day, but they're coming. Because it's considered standard treatment now. I want to stop that ventricular remodeling, stop that process from happening on the other side, and hopefully prevent them from coming into hospital every single week. Because you know this is one of the core measures. Heart failure is one of those things that you don't want to see a patient readmitted within 30 days. Or you could own that hospital stay. That's the issue that you have with patients who have heart failure. Big deal when you're in the hospital. And you may have seen when you went to when we went to clinical. We're going back this week. But when you look at things about, they always have stuff you have to chart on a patient who has heart failure. There has to be documentation that patients understand their medications, what the follow-up piece is, that kind of thing, because readmissions are problematic. On any given day, one of the things that they did is they did a report probably about 4 or 5 years ago about on any given day how many of your inpatient admissions were related to heart failure. And because we have so much older people here, it was greater than it was for the rest of the nation. But on any given day, you have a patient who was either admitted for acute heart failure syndrome, or if you're monitoring their heart failure syndrome, is 67 to 80% of the inpatient admissions any given day in the hospital are age 65 and over. That's just huge when you think about what's going on with the patient, and why it's such a big deal that we manage these patients a lot better than we're doing. Now, we do have patients that if they come in acute failure really bad, there is a synthetic form of beta-natriuretic peptide called Natacor. That you can give patients IV to help them diurese, but it's very expensive. So it's usually saved, preserved for certain patients. It's not something you give every day kind of thing, but it works fantastic, but it's just really expensive. Now, when I have a patient who has heart failure, I'm trying to figure out why this person comes to me. You look at their history, think about what they were admitted with, if they had this before. If it's a new onset of heart failure in a patient, think about if this person have an acute MI, because sometimes that'll happen. If it's a really bad heart attack and the pumping force of the heart is greatly decreased, they don't move stuff along, and patient can have acute heart failure. You see that as one of the complications of acute MI. Can also be with patients who have renal disease. Because remember, if they can't get rid of fluid has to go somewhere. So sometimes the heart, those types of things are going to be, and the lungs are going to be things that are a consequence of what's happening with the patient. So a lot of different reasons why a patient can have heart failure, but we need to figure out why, make sure we address those issues for that particular patient. Because we can put a patient into heart failure if we give them too much IV fluid. If they're older, if we give some patient blood products because they needed it, but I can still put them into heart failure. So you have to look at why the patient is having a problem and address those issues. If it's an ongoing thing, just know they're going to go home on some of these, several of them usually. Okay. You know, the big one now is, I can never think of this drug name that saved my life. Ernesto, I think it is. Ernesto, the two drugs that are in Ernesto, one is part is the ACE inhibitor, the other part is a new class of drugs that is used to treat heart failure. And it's one of those drugs that is showing such promise. We may not see patients hospitalized for heart failure in the next few years because everybody's going to be on this drug, which would be fantastic. But it's very expensive right now, you know, until they get a generic. You know, but they'll probably keep that one for a long time, just like Lipitor. Most drugs, when you introduce them to the market, have a patent for 7 years. Lipitor was the longest drug ever. Did not have a patent that only went brand name. It went for almost 17 years before they had a generic Lipitor. And y'all are going like, what difference does it make? If you got a patient who can't afford to take the medication, that's what the problem is. So now you actually have a generic form of that. This new stuff that they're using for patients, when you look at the first data that's coming out for patients and hospitalizations, is fantastic. Like nothing we've ever seen in heart failure management. Y'all go like, you sound so excited about it, because it is. To see people not, we used to call them frequent flyers in the hospital all the time. You know, they're here every 3 weeks, every 4 weeks, and for doing stupid stuff that they do. But a lot of it is because they don't take their meds. And the thing about it is, even though this med is expensive, they offer a lot of assistance for patients because they know that. But the end result is we're going to save a lot of money hospital-wide. Hospital-wide, I mean, as far as cost, when you talk about treating heart failure patients. Heart failure syndrome is probably like a $18, $19 billion business annually for most places when you talk about what's going on with patients as a state. So if you add that up for states, it's crazy. Because it's a lot of what we end up paying for Medicaid, Medicare, and for just in general, our insurance costs. It's a big one. So we got to make sure that we kind of reverse this stuff from happening in patients. This one is a big lifestyle modification, patient teaching piece, big time when we talk about heart failure patients. Okay. They need to know about the meds they're taking. Okay, you know about, because all these meds we talked about before, what you got to do for patients, let you know what kind of stuff they need to report. But their thing is always going to be about how they eat, what they eat. Because that sodium piece is a big deal. Patients don't realize how much it can make a difference, but that's on a low sodium diet can make the difference between you saying that I'm out of the hospital or I ate something and I gained 5 pounds, 6 pounds. When you start looking at 5 to 6 pounds, you don't start diuresing them, then they end up back in the hospital. So that's why it's a big deal. So understanding that whole thing about sodium, understanding about their medications, understanding that, you know, if you got a person that takes 4 or 5 pills, that all 4 or 5 pills need to be leaving the bottle at the same time. Every now and then you get a patient that says, I took all of these, so now I'll start on the other ones, and then I'll take the other ones. It's not a 5-month supply of meds. It's a 1-month supply. You should be taking them all together. And I know that sounds crazy, but people do that. They only take one of them and think that it's going to magically get rid of all the other problems they have. So education about their medications is going to be key. Because a lot of these people have syncope associated with their medications, rise slowly because they're never on one drug. So if I'm giving you a diuretic and I'm also giving you something to lower your blood pressure, syncope is a problem. So change positions slowly, and sometimes you just have to divide the meds. Sometimes you may have to give them the diuretic in the morning and the ACE inhibitor in the afternoon. Those are all like patient teaching points for the patient. But hopefully, you can get them to a point where they have some quality of life. Some patients will require oxygen at home, and they do a designation of patients who have heart failure syndrome. So it's like that New York Life, they have 6 stages that the patient has. And stage 1 and stage 2, and 1 and 2 is where you want people to be all the time. 1 is that you see the changes that are happening in the heart but no symptoms. 2 are going to be patients who have changes in the heart, mild symptoms that can control with medication. As you get higher in the list, those are people that go from being able to talk to you and keep us and make a sentence without being short of breath to a person who's taking a breath in between every sentence. You can't get up and walk to the bathroom. You can only tolerate walking 10 feet and then pass out kind of stuff. That's the stuff you get up into. And we used to call them cardiac cripples, essentially, because that's what we used to do. If we didn't make them get up and do stuff, that's what ended up happening to the patient. But now we want people to live a better quality of life. So that's why it's important to kind of make sure they understand that whole process. But it is one of the core measures. So when you go in the hospital this week, kind of look at that one for heart failure, and we'll talk about it in post-conference, and kind of look and see those kind of things that make it different about what you do for the patient, because it's really important that they do that. Now, one that kind of fits this, even though it's a different process, the end result is the same. And I'm just going to talk about it because that's the same thing we do. Oh, I forgot. We talked about Naticor. Do lab work first, I'm sorry. So BNP is the lab test I'm going to do about heart failure, being an natriuretic peptide produced by in the atrium. If a patient's level is high and they're short of breath, you know it's heart failure related. Because that's one of the things that they can do as a differentiating factor between something respiratory in nature versus something cardiac in nature. Because if you were in there with asthma, your BNP would be normal. But if I have heart failure, my BNP is going to be elevated. And sometimes you'll see readings that are out of this world. 12,000, 22,000. 22,000 is the highest one I've ever seen on a patient. It's 22 and change that a patient had in the hospital. Generally, you're going to see symptoms, or even before a patient has symptoms, the BNP is going to be positive. So if you, this is how you kind of pick it up. When you got people that tell you, my rings feel a little tight, my shoes feel a little tight, like you went to Chick-fil-A the day before. We talked about that before. But Chick-fil-A is wonderful, but it does have sodium. You'll notice the next day when you put on shoes and stuff, your shoes feel a little tighter, your rings may be a little tight. That's the kind of stuff you see before the patient is full-blown heart failure. Little nuances patient needs to monitor. Weighing themselves so they know if you gain 5 pounds in a day, that's not good. I need to diurese you before you come to it. Don't be sitting there waiting until I can't breathe no more. I want you to diurese then. I mean, I have to bring you into the hospital if you start taking extra diuretics then. I have potassium for you. I have Lasix for you. I want you to take this. Weigh yourself in the evening. Let me know what it is. That's the kind of stuff you can do to keep people out of the hospital. But a lot of times people don't do that, and they just end up in the hospital. I mean, that when you get there, they're going to do the same thing, diurese you. But I'd rather stay at home instead of being exposed to all kinds of evil in the hospital. I'm just saying. I end up septic with a trait, and then I'm going to die. So that's why I would rather be at home doing that kind of thing. So that's, you want to make sure patients understand those types of things that go with that. All right? But one of the things that is similar, different process by which it happens, but the similar kind of symptoms, presentations, that kind of stuff you see in a patient will be that person who has cardiomyopathy. Okay, cardiomyopathy ends up, it's going to be a stretching out of the muscle in the heart. It's either dilated or restricted, and they're talking about how the heart works itself. But the thing about it is that the pumping force of the heart is gone, and the myocardium itself gets enlarged and floppy. So that's what we call it. CMO patients are large, floppy heart. Remember we talked about the intercostal space you listen to, fit intercostal space? When you're talking about a CMO patient, you may be listening to 6th, 7th, 8th intercostal space. If you think in your head how big that person's heart is, yeah, it's that big. And when they're doing a transplant, that big old heart stays in there. You don't take it out. You just put the liquid next to it. Because it's huge. You're talking about somebody who's going from this to one of those little Nerf footballs, or the medium-sized Nerf football that's inside their chest. But the muscle of the heart is bigger, but it does not work as well. This goes back to Starling's law. If you keep stretching something out, what happens? It loses its ability to contract. So that's what happened to the heart. It gets big and floppy, but yeah, it pushes stuff along, but not so great. Yeah, it pushes stuff along, but not so great. So you have decreased cardiac output because of that. So the symptoms that you see in the patient are going to look just like a heart failure patient. So that's why I say, even though it's a different process, same kind of things you're going to see in your patient. What also accompanies it usually when you're talking about heart failure, because heart failure is something that happens because a patient has heart attack, kidney problems, that kind of stuff. But with cardiomyopathy, there's usually a rhythm issue happening as well. Okay, so they can have AFib, they can have BTAC, those types of things. So that's the kind of thing that makes it a little different, because you see that heart failure patient comes in because a lot of times known history issues that are happening with your patient. A CMO patient, usually is somebody who never had a problem before, comes into the hospital, has this problem, full-blown heart failure. You're going, what? They have AFib with RVR, and you're going, what? This person never had this before. It's especially expected in young people. And one of the biggest groups that you see it, and there was a study that was going to be done actually, because they asked a couple of patients when I was with students at Tampa General to be in the program, is you see it a lot in teachers and policemen. They end up, and the theory behind it is that they have jobs where you're, you know, like if you're in front of people, you don't like to talk in front of people, nervousness, does that affect epinephrine and norepinephrine on the heart causes to happen? A policeman has to be ready to shoot somebody all the time. Does that, you know, excitement or that kind of thing cause that effect that's happening in the heart? There was some speculation about this, so they were doing a study about it, and they were asking people to do it. And I had never thought about it. You know, I just see people have it, and I know it's bad. But the thing about it is that when you start looking at the patients that you take care of, yeah, that's who you see a lot. Sometimes you see athletes who have it because, yeah, they're in their life, what they're doing is always competing, getting ready for that next thing. Was that something that was causing this problem in the patient? So there are some theories about whether or not that's where it comes from, but we don't know why it happens. A lot of times it's related to some type of infectious process. I have a patient, actually, who became a friend after the fact, that had cardiomyopathy. And his thing was, and the reason that we became friends was because he said, "You saved my life." And I was like, "No, I didn't. I just took care of you in the hospital." He said, "No, you told me not to go home, and I didn't," kind of thing. But this particular person was a sheriff in Manatee County, and he went to some competition up in North Florida somewhere. And on his way home, he just got so short of breath. He said, "I felt like my legs were fat, but I didn't really think about it. I just thought it was from sitting and driving." But he said he got so short of breath till he saw the sign on 75 that said it was a hospital, which you turn off on Fletcher. And he went to Florida Hospital, what was University Community at the time. And he said that I got off because I couldn't breathe. They tried to get me out of the car and I couldn't get out. He said I just went and drove up to the thing. He said I couldn't get out of the car. So he goes, they take him in. He is in full-blown heart failure because his legs are puffy because they had to cut his pants off. His legs are still edematous. He was short of breath. He was in atrial fibrillation with a heart rate in the 170s. Okay, so then they're asking him about, of course, they go into the history mode. What are you doing? What have you been doing? This kind of thing. He says, all I remember is a couple of weeks ago I had the flu or something like that. And then I just started feeling bad, but I didn't really think anything about it. Because, you just work through it, like you do. Like when you don't feel good, you just work through it to the next thing. So he comes in the hospital in full-blown heart failure. So he's in the ICU. They anticoagulate him, try to cardiovert him. It works for a day or two, and then he goes back into his AFib. And so they put him out on the floor, put him on Coumadin, and they were going to wait a couple of days to try his next cardioversion. And so his comment to me, he was upset. I had assigned him a student, and the student was getting ready to give him meds, and she comes out and tells me, she said, "Ms. Henderson, he's threatening to leave the hospital." I said, "Well, why is he threatening to leave the hospital?" He wants to know why all the crib keepers go home and he's still here. And I was like, "Who are you talking about?" And he was talking about those old patients in the room with him, because this guy is like 33 years old. And everybody 70, 80 years old is coming in the room with him, having their procedure and going home, and he's been here a week. So he doesn't understand that. I said, well, he doesn't understand that's pipes versus muscle. Pipes you can clean out. That's why the people are going home. That's why I explained it to her, and she said, well, can you come tell him that? And I'm like, why don't you go tell him that? I just told him. But anyway, so we go in there, and we talk to him, and he's just adamant that he's going to leave. First thing I tell him, I said, you do know if you leave AMA, they can go after you for the money that you spent here. If you've been here for a week, you owe a lot of money. So I wouldn't do that. Oh, okay. That's the first thing. But then I draw pictures for him, because sometimes that's what you have to do. Patients need to understand. This is a picture of what's happening. He doesn't understand why this man, he's just like the fourth patient that has been here this week that has gone home. They have a cardiac cath and they go home. So then I explained to him about what the difference is. They went and cleaned out the area where they weren't getting circulation. So they reestablished circulation for these patients, put in a stent, make sure they're not bleeding. That's why that person goes home. I said, what you have is essentially your heart just laying there, beating really slow. I mean, not beating slow, but beating really fast, but your ejection fraction is 18%. The normal ejection fraction is 60 to 65. his is 18. When you get to 20%, you are evaluated for a heart transplant. Because that means that just getting up to the bathroom, you're winded. And he was winded. Walking down the hallway, couldn't hardly be. I saw him walking around, trying to walk around. And he'd have to sit down and that kind of thing. But